afternoon, everyone. We will be getting started in 5 minutes, right at 2 o'clock. Thank you all for joining us today. Hey, Dr. Pomm, I just let everyone know that we will be getting started right at 2 o'clock.
All righty. You can hear me?
I can hear you.
Very good. How many attendees do you think?
Currently, sorry, I accidentally muted myself while I was speaking. Currently, we have about 20, but we should probably have more joining us towards closer to 2 o'clock.
How many registered? Curious.
I am not sure how many registered at this time. Eric, do you know by any chance? Did you check it before we started the meeting?
I didn't check it. I'm not sure.
Good afternoon, everyone. I'm Rebecca Vickers, and on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar. This webinar is being made available through a collaboration of the Florida Department of, with OSCA and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and me, the host, by using the chat panel. The button to open the panel is usually located in the lower right side of your monitor. Please use the chat panel to send any questions you may have as you think of them. The presenter will address questions as time permits. Our audio is broadcast through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen right now, and these options are posted in the chat panel. If you continue to experience poor computer audio, try rejoining the webinar and use the I will call in telephone option. You must be connected to the audio of this presentation and view it on screen to receive a certificate of attendance. The recording and materials used in today's presentation will be available on FADA's website within 30 business days. FADA produces many webinars and workshops through the support of OSCA. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credits for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on FADA's website. You will first need to register or sign into your account to complete the evaluation. Information you provide FADA as a part of registering remains confidential. Statements of credit will be posted 30 business days after the evaluation closes. Completing the evaluation is necessary to receive CE credit or to access a statement of credit. Please note the evaluation will close Friday, April 15th. Up to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, be sure to include your Florida license numbers for reporting to CE Broker. If you are licensed outside of the state of Florida, you do not need to provide your certification number when you register with our site. Please note that WebEx monitors arrivals and departures of attendees and provides a report upon completion of the event. We are not permitted to provide a certificate of attendance if you do not attend the entire webinar, and we are not permitted to provide partial CE credit. Dr. Pomm is a board certified in psychiatry, addiction psychiatry, and addiction medicine. He is also a certified medical review officer. Dr. Pomm served on the Governor's Commission on Mental Health and Substance Abuse. In 1992, he began working for the Impaired Professions Program of the state of Florida, the Professional Resource Program, PNR. From 1998 until 2011, he served as the medical director for this organization. PRN serves 29 healthcare boards and councils on matters relating to healthcare professionals' impairment. Also, from 1994 to 2010, Dr. Pomm was an expert consultant to the Florida Board of Bar Examiners. He served as a medical director for River Region Human Services from 1994 until 2017. Dr. Pomm serves as the Chief Medical Officer for Gateway Community Services in Jacksonville, Florida. He is a Courtesy Associate Professor in the Department of Psychiatry at the University of Florida. He has been a leader in the addiction field as it relates to the evaluation and treatment of co-occurring disorders and management of impaired professionals. And now I'm going to turn the presentation over to you, Dr. Pomm. Here we go.
Thank you very much, and thank you for inviting me to share this presentation. I hope everyone can hear me okay. This has been a really trying time for our society when fentanyl basically came into our picture back in 2014, 2015. It's not that co-occurring disorders didn't exist before then and they weren't confusing at that time. It has become even more confusing now because, as you will see as I discuss further, there are so many drugs being abused all at the same time. We're seeing fentanyl mixed in with cocaine, with methamphetamine. We're seeing cocaine addicts who had never done fentanyl before, having fentanyl in their system, methamphetamine addicts who had never done fentanyl before, and that's in their system. Fentanyl addicts who had never done the cocaine or methamphetamine, having that in their system. Also, we're talking about enormous amounts of alcohol I mean, in the state of Florida, it was considered an essential business, and addicts and alcoholics took that to heart, seeing enormous amounts, upward of a half a gallon to a gallon of alcohol at a time. I never envisioned anything like this happening. In addition, we see, benzodiazepines or tranquilizers. So we have such a complex picture of people coming in, especially to Gateways Detox, which is where we're seeing it, or Project Save Lives, which is our emergency department program. We're seeing people who are physically have not taken care of themselves, but in addition, they're presenting with various psychiatric conditions, including, especially for this presentation, psychosis, amongst the various other symptomatologies associated with the drugs they're using. It's become an extremely complex picture. And I can tell you, I know Gateways Detox, it's more like a behavioral ICU at times. So what I'm going to try and do is unravel this. We're going to be looking at the various disorders we commonly see, how they can be assessed as to what they really are and what might be the etiologic factors affecting them, and whether it's going to require acute treatment, what that acute treatment will be, versus longer term treatment. Is it a primary or secondary symptomatology? So I'm going to try and make heads or tails out of this, and hopefully I'll do a decent enough job. What I'm going to start with then is basically just looking at the co-occurring picture period as it relates to the various psychiatric illnesses. Then I'm going to weave in all the various drugs, and then we're going to have the last large portion of this as scenarios, and we're going to ask for audience participation in terms of trying to figure out what exactly it is I'm asking, trying to answer the questions, and then hearing how I view them. So with that introduction, let me go ahead and get on with the presentation. So I'm not function key, and I'm not moving forward, backward, or anywhere.
You may need to click on the slide first, and then you should be able to use.
Not that piece. Okay, that did it. Oh. All right, schizophrenia. I've got to share this with you. It's very frustrating to me. We have a lot of people that are coming in with psychotic symptoms or a history of psychotic symptoms. They have been previously diagnosed with schizophrenia, have been on multiple really sort of heavy-duty medications. But when we look at their actual history and the way they're presenting at the time, they are not schizophrenic. It's very frustrating for us, and I'm sure also for the patients, when they're diagnosed with such a chronic illness, and yet an appropriate history hasn't been gotten, and it's sort of just been given to them. I can say this, and I'll say this about another condition too. Only 1% of the population is truly schizophrenic. I swear to God, 90 to 98% of that 1% are in Jacksonville, Florida, because so many people come in with a diagnosis of schizophrenia. And I want to make sure we start off with exactly what the criteria are. All right, so it's very important to see. It's got to be 2 or more of the following: delusions, hallucinations, disorganized speech, grossly disorganized or catatonic behavior. Usually, people with disorganized speech and grossly disorganized behavior do not end up with us. They end up in a primary psychiatric unit. Negative symptoms are not unusual. Flat affect. They don't move very well. They don't speak very well. There's not a lot of energy behind those. Those are negative symptoms. Mostly what we see are delusions. I want to make sure everyone understands delusions are false beliefs. And we'll talk a little bit about how to work with patients that are having delusions. And of course, hallucinations can be anything visual, auditory, gustatory, which is taste, olfactory, which is smell, tactile, which is touch, various delusions. So they've got to have at least two. That's extremely important. I'll go that way. Other piece that's extremely important is social and occupational dysfunction. Over the course of time, over the course of at least 6 months, socially and occupationally, they have basically been significantly impaired, and it has usually progressively gotten worse. Now, you already see that B, the criterion B, can be seen in the addict and alcoholic. And you could actually sometimes see in A, 2, more often we see 1, but you can also see 2. So you can see where this can look like schizophrenia, but it really isn't. The duration of at least 6 months, obviously, most addicts and alcoholics that we work with have been using drugs for years. So you can actually understand why there might be some confusion if one doesn't get an absolute adequate history. All right, and we're going to come back to schizophrenia along the way when we talk more about some of the drugs of abuse. So there's something called a brief psychotic disorder. This is where someone will have psychosis. It's one or more of the following. Again, the same delusions, hallucinations, disorganized speech, grossly disorganized behavior. You need one in this situation, and the duration is less than 1 month, okay? After which they return to normal functioning, before which they were normally functioning. When we say normal functioning or pre-morbid level, they didn't have the delusions, hallucinations, as an example, okay? They came and then they left. And that's extremely important too in terms of a differential diagnosis when people are looking at drugs and drug and alcohol usage. This one, everyone I talk to becomes very confused with schizophrenia. And oh, before I go further, I just want to let you know, this is DSM-5. Now, DSM-5 TR, which is an updated version, has already been published. It's going to be, I'm waiting for my copy, and according to Amazon, it's coming next week. I haven't seen it. There are changes, but I don't believe the things we're going to be talking about are going to be changed to any great extent. These have been fairly commonly used, and the criteria haven't changed much from DSM-3 to DSM-4 to DSM-4 TR to DSM-5. Okay, so we're on pretty safe ground understanding this as we have been experiencing it and as we're likely to experience it moving forward into the future. All right, let's look at schizoaffective. And I've had this discussion now probably 2 to 3 times a week over the last several weeks with varying clinicians who have been confused with this. I can read this, and I will. Then I'm going to simplify it, okay? So I don't like reading slides, but I'm going to do it in this situation. An uninterrupted period of illness during which, at some time, there's a major depressive episode, a manic episode, or a mixed episode concurrent with symptoms that meet criterion A for schizophrenia. Remember that, criterion A for schizophrenia. I'll come back to that in a minute. Delusions or hallucinations for 2 or more weeks in the absence of a major mood episode during the duration of the illness. Then C, symptoms that meet criteria for a major mood episode are present for the majority of the total duration of the active and residual portions of the illness. All right, you know, that sounds really confusing. It sounds confusing to me. And I want to simplify it the best I can. Basically, with schizoaffective disorder, we have 2 disorders going on at the same time. One disorder is a mood disorder or affective disorder. It could be major depression. It could be bipolar disorder. Okay. So that exists. That disorder exists independent of any psychotic symptomatology. Then you have this, I hate to say, schizo part of that diagnosis, which is also independent of the mood disorder. And we'll get into how that manifests when we talk about mood disorders, but it's independent. So you have two independent disorders going on. I want to make sure you understand that for this quote unquote schizo part of that, they must meet the criteria A for schizophrenia. Criteria A for schizophrenia is 2 symptoms, not 1, 2. More than likely, it's going to be hallucinations and delusions. Okay, unlikely going to be disorganized speech or the appearance being sort of disheveled. It's unlikely going to be those 2, though it can be. More than likely, what we're going to see is hallucinations and delusions. It's got to be both. Where it can get confusing is with the negative symptoms, because if they're depressed, those symptoms, flat affect, alogia, slowness of movement, slowness of speech, they can also be symptoms of depression. I'm not going to worry about that so much right now, but I want you to understand there have got to be 2. They got to meet 2 criteria A for schizophrenia, which is 2 symptoms, and have met the criteria for depression, okay, major depression, and or bipolar disorder. Okay. So what can happen is this. A person could be depressed off and on for years, and every once in a while, they'll develop 2 symptoms of criteria A of schizophrenia. So they could be depressed, and then they can become psychotic, where they reveal symptoms of psychosis, hallucinations, delusions, and then those symptoms can go away, the depression continues, or they can be depressed, the depression goes away, but the psychotic symptoms are there without the depression, for the depression only, or bipolar disorder only to come back again. So you can see there's a fluctuation of 2 different disorders going on. Sometimes they overlap and sometimes they don't. Let me give you a quick example. Actually, one of the first patients I ever saw as a resident in psychiatry was this early 20-year-old female who had been in and out of state psychiatric hospitals since her early teens. Really sad. Had been placed on all the major medications for psychosis, had been diagnosed chronic schizophrenia, and she had gotten nowhere in life at all. Well, and by the way, just let me tell you, the prognosis for schizoaffective is far better than the prognosis for schizophrenia. And I'm going to show you this example. When I saw her, she believed she had a radio in her stomach. That's a delusion. She also heard the music. That's a hallucination. So there you've got 2 criteria. I could have left it at that, but the problem is her history was muddied because she was in and out of state psychiatric hospitals. I didn't see the degradation in psychosocial functioning because she never got anywhere. She was always hospitalized, way over medicated, and came out, became non-compliant with medication, became symptomatic again. And something in me said, okay, this person is not responding to the medication. This person is not responding to treatment. It was a really sad situation. She was very bright, and she was able to be animated in conversation, which for chronic schizophrenia, they usually lose that affective flexibility, where they're usually very flat. They don't let you get real close. They're not very animated or engaging. So the fact she was animated, engaging, and it just didn't add up to schizophrenia for me. So I talked with her parents, and her parents told me she had been depressed for years before her first psychotic episode. And in fact, during her presentation at the time I first saw her, there was definitely evidence of depression. So here I was, I'm going to go ahead trying to treat the psychotic symptomatology with medication, but now I added in an antidepressant. And what happened was she got better, because without treating both, they're not going to get better. She not only got better, she went on and graduated college. She got a job, a very successful businesswoman. So that's how important it is to come up with the right diagnosis, which leads to the right treatment, which then leads to improvement and improved prognosis. When you say schizoaffective, they want you to speak to what is that mood component, that affective component. So if they're schizoaffective and their most recent mood component was bipolar, you say schizoaffective disorder bipolar type. If their most recent was depressed, then you say depressive type. Catatonic, we're not going to talk about so much because it's pretty rare. Okay. One of the frustrations I have with webinars, I don't see people's heads nodding. I don't know if you're getting it, so I'm assuming this is making some sense to you all. Delusional disorder, another type of psychotic disorder, is a very circumscribed, symptom-based presentation. Then delusions are false beliefs. When a person has delusional disorder, outside of the content of the delusions, they function very well in the world. Okay? So, one thing is, they should never have met criterion A for schizophrenia. Remember, when they say criterion A for schizophrenia, it's two different symptoms. Here it's just delusions. In order to meet the criteria for delusional disorder, they must never have had hallucinations. Okay? Again, as I was saying, functional impairment is related to the delusional theme. Behavior is not bizarre, and I'm going to give you a couple of examples of this. But they're very fixated on that one delusion. It's very circumscribed. Okay? Sometimes you have mood symptoms in reaction to the actual delusions. So, examples. Erotomania. Okay? You see this in the newspapers where someone has a sexual fixation on a particular person and believe they're in love with them, and they do everything they can to get into their lives. They end up stalking them. You've seen that before. A grandiose type, where they really believe they have special powers beyond that which is reality-based. Jealous type. This is probably something you more commonly see in our field on a day-to-day basis. I'll give you an example of jealous type in what I've done. In my experience, was one example, a woman swore her husband was having an affair. Well, you know that's true. She was very frustrated with the situation, wanting a divorce, distressed, but it was only about the marriage. She was able to go to work. She was able to function. It was only about the marriage. Brought him in. Of course, he was convincing. Well, so, you know, it was very difficult to discern, do I believe, do I not believe? And at the same time, her reaction to it was such, it went a little further than I would typically expect. She and I came to an agreement. Let's try a low dose of an antipsychotic medication, okay? Just a low dose, and see if that can help filter some of her thoughts and feelings and stabilize some of her functionality. I did that, and what do you know? Her husband wasn't having an affair anymore. And actually, they were very happily married. So that was a tremendous example. And I'm not suggesting that you do a test dose of antipsychotics whenever people have affairs. It gets a little more detailed than that. Then there's persecutory, where you feel, it's paranoid basically, where you feel people are against you, people are plotting against you. I had a woman that swore at her office that it was bugged and they were trying to catch her doing things. And she functioned really well in her job. She functioned outside of her job. But when it came to being in her job, she was always concerned because she knew people were watching her. Again, a little antipsychotic medication, and it was no longer an issue. For both people, they needed to be on it for a significant period of time. It was low dose. We tried coming off, and the symptoms reemerged. So we had to put them back on. Usually it takes a very, very low dose. Then there's somatic illnesses, for instance, or mixed combination of these. Again, the important thing here is that the symptoms are very circumscribed. Okay, their responses don't go beyond the actual delusion. All right, so now we have some specifiers, and I'll just fly through these pretty quick. Basically, for all the ones I discussed, first episode, you want to say it's acute, could be in partial remission, could be in full remission. They could have had multiple episodes. It could be continuous. There's been no resolution, or you don't quite know what to make of that. I can't give you an example of that. And then, of course, current severity, anywhere from zero, no symptoms really, or not much, very severe at all the way to present and very severe. Look, 4 should be really hospitalization material. 0 to 4 is anywhere from nothing to that. It's somewhat subjective. Okay? All right. Now, this is an important category in any diagnosis that one would have or one would be given. So a lot of times we'll have people who don't quite meet the criteria for a disorder we're pretty sure they have, but they don't quite meet it. And now I'm going to talk a little bit more about other than just other specified schizophrenia spectrum. I'm talking about any diagnosis that you might give. I actually, for as much frustration I have with DSM-5, I like this category, this option for diagnosis in DSM-5. Because what it allows you to do is specify what you're thinking. Remember, your evaluation and your write-up is for the reader, okay? They don't know what you're thinking. So this is a way of telling them what you're thinking. So I'll give you an example outside of the schizophrenia, and I'll come back to that. It pops up quite often. They don't quite meet the criteria for PTSD. So you would say other specified trauma and stressor-related disorder does not meet criteria for PTSD. You're telling it in the diagnosis. Anxiety, let's say they have GAD. You think they have GAD, but they don't quite make it in terms of DSM-5 criteria. And you can say other specified anxiety disorder, does not meet criteria for GAD. You're going to treat it like they have the disorder because they're probably symptomatic and need treatment. Otherwise, they wouldn't be coming to you. But you're telling the reader and you're reminding yourself that, hey, it's so close, but I can't quite get there. In this situation, other specified schizophrenic spectrum and other psychotic disorder, that's just a mouthful. By the way, I don't like the terminology at all because it sort of puts everyone in that schizophrenic category, and they're not. But this is what we've got. So here it is. They don't meet the criteria for any one particular disorder, like schizophrenia, delusional disorder. They don't quite meet it. But they have certain symptoms. And here they allow various examples. We see this quite a bit with persistent auditory hallucinations. So someone's having auditory hallucinations, and that's all they've got. You know where we see this quite a bit, and I'll talk about it in a little bit. It's with PTSD quite often. And in this situation, it would be other specified schizophrenia spectrum, other psychotic disorder with persistent auditory hallucinations, okay? You might have someone that, not quite delusional. They think, but it's not quite there. They see things, but they're not quite sure. So it doesn't quite meet hallucination. In that case, we'd call it attenuated psychosis syndrome. Okay. And the other one is delusional symptoms in partner of individual. That's where we used to know that as folia do, where a partner of an individual who has a delusional disorder, so the partner didn't, the individual does. Okay, now the partner develops the same symptoms, and that we used to call folia. All right, then we have this other category, which you can use for all the other disorders also. Unspecified. That's where you know they've got some psychotic disorder, but they don't come close to meeting anything. I'm not sure what it is. It's unspecified. So you're telling the reader again, look, they've got a psychotic disorder. I don't know what it is. It's not close to anything in the book, but it's enough that I need to treat. I need to pay attention. I need to treat. Maybe we need more evaluation. Quite often that's the case. And that's where unspecified would come in. Okay, that's it for psychotic disorders for now. We're coming back to them. Mood disorders. Keep wanting to press the wrong button. Let's talk about depressive disorders. All right, major depressive disorder. This is something I'm sure you're all very familiar with, so I'm going to go through this. You've got to have at least 5 for a 2-week period. Again, depressed mood, unable to enjoy things like you used to, which is anhedonia. Important. It's not just decreased appetite. It's weight loss or weight gain. It's not just decreased appetite. If it's just decreased appetite, you cannot give number 3. Okay? Insomnia or hypersomnia. People with major depressive disorder are very tired. They want to sleep or they can't wake up. It becomes very dysfunctional. They're very slow in motion, which is psychomotor disturbance. Diminished self-esteem or guilt, impaired concentration, and recurrent thoughts of suicide. So 5 of those are important to have in order to give the diagnosis. Now, I can tell you, partial or full remission, sort of this is how I summarize it. Partial remission, if they're on medication, they don't have all the symptoms they did before, but now they're on medication and they only have 3 symptoms left, which is it's not unusual. Then you got to get partial remission if they no longer have the symptoms, they had a history of it, or they're being treated and they no longer have symptoms, then of course it's full remission. Now, mild, moderate, severe. I'm going to make this really simple. Okay, they can't function at all. It's severe. If they can function with effort, that's moderate. If they can function with just a little effort, that's mild. And it's that simple. This is where I want to go with this. Major depressive disorder. I'm not here to talk about all the other ones. We don't have time to do that. We're here to talk about psychosis, okay? Congruent psychotic features and mood incongruent psychotic. I talk mostly about mood congruent psychotic features and mood incongruent psychotic features. So, mood congruent psychotic features are, they're very depressed and the world is going to be destroyed, as an example. I know the world is going to be destroyed. The voices are telling me the world is going to be destroyed. Or my body, I have cancer. Or I'm going to dissolve into nothing, the delusion, nihilistic delusion. So that's congruent. It is not congruent if they are depressed and feel like they are on top of the world, they are here to save the world. That's not congruent depression. Okay? That's why it's incongruent. Now, let me explain really carefully. Major depression with mood congruent psychotic features or incongruent psychotic features. The psychosis occurs at the severity of the depression. Quite often, it doesn't happen when they're milder symptoms. It quite often happens when they're more severe. But the important thing is The depression brought on the psychosis. You treat the mood, you might have to treat the psychosis first also, but when the mood stabilizes, the psychosis goes away. That is very different than schizoaffective disorder, where you have the mood is independent of the schizophrenic-like symptomatology. They can both be together, but they also both occur independent of each other. So it's really important to understand this is totally associated with the depression. All right, let's talk about bipolar disorder now. Again, I got to share with you, it's very frustrating, just like schizophrenia. About 3% of the population is bipolar. I swear to God, 99% of bipolar folks all live in Jacksonville. It's extremely frustrating to me, especially in the context of drug or alcohol abuse, because they overlap with symptoms. It would be almost impossible in the population I see to give a diagnosis of bipolar disorder given their history of drug and alcohol use, and we'll get into that a little later. But it's given all the time. It's just amazing. I would say that 80% of the folks coming through the doors at Gateway, and when I was at River Region, same thing, have bipolar disorder diagnosis. You know, and the patients become attached to it. I'm bipolar. I'm bipolar. They identify as bipolar. I need medications for my bipolar. And it's amazing how many people have never had a true manic or hypomanic episode. Never. Or if they did, it's while they were using drugs only. And again, we'll get into that. So what a manic episode looks like, obviously, a distinct period of abnormally persistently elevated, expansive, or irritable mood lasting at least 1 week. Okay? So what are we looking at? Inflated self-esteem, talkative. Okay. Usually they're very pressured with mania. It's very hard to interrupt. In flight of ideas, they go from one topic to another topic to another. No matter what you say, you'll bring them back, and then they go off on a tangent again. Highly distracted. You know, anything goes on, they're looking at. And by the way, just saying, this is not ADHD. It's a whole nother discussion. But a lot of folks are given the diagnosis of ADHD with these symptoms. And this is, let me keep going. I'll say one other thing. Increase in goal-directed activity. Okay. So here you're talking about socially getting more involved, sexually getting more involved, could be psychomotor agitation, really very, you know, I can't even begin to tell you the severity we're talking about. I had one patient who could not stop singing, was highly distractible, would get up and dance in the middle of the interview, would run up and down the hallway in the middle of an interview. I had a 90-year-old woman. I was scared she was going to die. She could not stop moving or talking, could not, and rambling with the tangential, with the flight of ideas. And of course, excessive involvement in pleasurable activities. So the excessive buying, sexual discretion. So obviously, drug use is another one which complicates the picture, obviously. Hypomania, the biggest difference is severity. With manic episodes, I rarely see truly manic episodes that haven't at some point probably needing to be hospitalized at some point. Hypomanic, they never quite get there. Quite often, they are an employer's dream employee. Now, this one only needs to last 4 days. Again, very similar symptomatology, inflated self-esteem or grandiosity, decreased need for sleep. The big difference between the inability to sleep with depression, where they're tired, they want to sleep, and hypomania or mania, where they don't want to sleep. They don't need to sleep. Okay? Again, pressured speech, flight of ideas, distractibility, everything I've said before. its severity is a big issue as well as length of time. Okay. So bipolar 1, both bipolars, typically a major depression is there. With bipolar 1, you have to have at least one manic episode. You don't need major depression with bipolar 1, but you know what? The majority experience a major depressive episode somewhere in their lives. But at least one manic episode, you are now manic, not hypomanic. You are now officially bipolar 1. Okay, and you got to specify what it is you're seeing at the time, or the most recent episodes: manic, hypomanic, depressed, or unspecified. Okay, mild, moderate, severe, same issue as major depression. You know, the severe, you can't function at all. A moderate, function with some effort. Mild, with less effort. Again, psychotic features. This is what we're talking about today. Psychotic features here are as the symptoms of bipolar 1 become more severe, that's when the psychotic features usually come on board. Okay. Again, mood congruent. Here, it's just the opposite, where the congruent, you know, if they're manic, I'm the savior of the world. That's congruent. Incongruent, you know, here's bipolar 1. However, I'm here to destroy the world, or the world is going to be destroyed, or I'm dying. That would be incongruent with mania, because, you know, mania, you're on top of the world for the most part. You could be irritable, but that's where mood incongruent and congruent features comes in. Again, schizoaffective disorder. I've got to go back to that, all right? The difference is, with schizoaffective disorder, you have bipolar symptomatology independent of the criteria A of schizophrenia, and two symptoms, okay? With bipolar 1 with psychotic features or major depression, you could have just one psychotic symptom. However, with schizoaffective, you've got to have the two, and they're independent. There are times where you can be bipolar and meet the two criteria for criterion A. That would be schizoaffective bipolar type. Going back to depression, there is a time where you could have two criteria of schizophrenia, of criterion A of schizophrenia, and be depressed, and that would be schizoaffective depressed type. In this situation, you don't have psychotic symptomatology without having symptoms of bipolar disorder. And when the symptoms of bipolar disorder are treated, you no longer have the psychotic symptoms. Extremely important to understand. Bipolar 2, basically, they've never had a manic episode, but they've had a hypomanic episode. Okay? And they've met major depressive episode at some point in their life. Again, with bipolar 2, you got to say bipolar 2 with hypomanic or with depressed or over depressed mood, or depression, I should say. And mild, moderate, severe, same situation. Partial, full remission, same exact situation as I described. They might have only some symptoms with treatment. They might have no symptoms with treatment. They might not be in any treatment, and they are fully, you know, with no symptoms, that would be full remission. Again, same situation with bipolar 2. Though I'll be honest with you, I don't ever really see psychotic features with bipolar. But I'm not saying it can't exist. The more severe the illness will bring on the psychotic symptoms. You treat the illness, they go away. You might have to treat the psychotic symptoms at the time, but the treatment is only going to be necessary for any of these mood disorders with psychotic features. If you have to treat the psychotic symptoms, it's only for a period of time until the psychosis goes away, the mood is stabilized. Once the mood is stabilized, you can take the antipsychotic medication away. I get very frustrated when people are on antipsychotic medications for years and years and years and haven't been tried off, even though their mood is okay. And they'll be called schizophrenic because they've had hallucinations or delusions. And it just isn't so. Or They've never been tried off, even though their mood is stable. And the only episode of psychotic symptomatology was during the time of the more severe illness. And again, they're called schizophrenic. No, just because they had it then, I don't want to go over this, all the criteria for schizophrenia. They don't meet all the criteria for schizophrenia. This is strictly tied to bipolar and shouldn't really need the antipsychotic unless you're using it for mood stabilization. That's a whole different story that we're not going to get into. All right, here we are again with the other specified, very handy, where you have some folks that don't quite meet it. For instance, other specified bipolar related disorder, you don't meet the 4 days, you only have 2 to 3. Okay? So that would be other specified. And you put in there short duration hypomanic episode with major depressive episode. Okay. Or the hypomanic episode might not have enough symptomatology to quite meet hypomania. Okay. But you've got several and the major depressive episode. Okay. Or you've had a hypomanic episode without a prior major depressive episode. And you can see that. I'm not going to get into cyclothymia today. All right. So it tells again the reader, look, I really believe this, but they don't quite meet it. Therefore, I'm going to give it other specified. And unspecified, where you think they're bipolar. They seem to be bipolar, but they don't even come close to meeting it. But I'm thinking about it, and we're going to continue to assess. Either one, you're going to continue to assess. Okay. PTSD. I mentioned this before. I sort of, in my experience, I would like DSM to be giving an option of PTSD with or without psychotic features. They do not. It does not give that. So often, I will see people with PTSD and they're having auditory hallucinations, and the voice is of the perpetrator, or where they're hypervigilant and avoidant of potential triggers. It goes almost extreme to delusions. I know this is going to happen. I can't go here. I know this is going to happen, or this is going to happen to me, almost to the delusional, not just reactive, to the delusional. You can't really give post-traumatic disorder with or without psychotic features. So in that situation, you sort of have to say post-traumatic disorder, and then you would give unspecified, like, schizophrenia, that long thing, or other specified, depending on how close they come to meeting another diagnosis. Quite often it is unspecified, or it could be PTSD with some kind of delusion. Quite often it is the other specified, where it's persistent auditory hallucinations. Just to give you some examples of how to use that. I really see so much of it. I wish they did have a diagnosis. I know they're waiting for the research to come out. I just haven't seen any research. All right, so let's talk about the co-occurring. Now let's bring the drugs into the picture. With marijuana, I rarely see frank psychosis, rarely do. What we might see is some mild paranoid ideation. Again, ideation is, I think, not I know. I think this is happening. I think this is going to happen. That's ideation. Delusion is, I know this is happening. I know this is going to happen. Okay. So interestingly, with marijuana, acute psychosis is more common with edibles. Okay. All right. I'm focusing on the psychosis because that's the topic of the day. Okay. Interesting. Marijuana is delta-9 tetrahydrocannabinol. So marijuana has the delta-9 as well as CBD, cannabidiol. Interesting. Cannabidiol has an anxiolytic or anti-anxiety effect. It also has some mild antipsychotic effect. So you're all familiar with K2 or spice, or any of the Ks. There's a K3, K4, K5. You'll have to excuse me real quick. My dog wants out of this room. So I'll be right back. Sorry. This is what happens when you, oh, I'm back. All right. K2, besides the chemicals I spray on it when it first came out, especially, was strictly the tetrahydrocannabinol, tetrahydrocannabinol, not the cannabidiol. Delta 9 THC is what we call psychotogenic. It can bring on psychosis. When it's in conjunction with CBD, which is the normal plant marijuana that's smoked or eaten, there's that counterbalance with CBD. With K2, there's no counterbalance. So you will see people who have been using K2 who are frankly psychotic and agitated and all over the place. That's because the CBD part is no longer there. It's not there, period. Okay. All right. Chronic use, we don't usually see chronic psychotic symptomatology with chronic use. There are other things that we do see. Again, I can't get into all that today. We don't have time. Alcohol, very important. Okay. During intoxication, okay, they can look very agitated, very manic looking, very high doses. They can be depressed looking. During withdrawal, this is the important piece of this. During acute withdrawal, they can have delirium, which is clouding of consciousness, and frank psychosis. You can see visual hallucinations, that's quite common, but they can also have visual hallucinations and auditory hallucinations and tactile hallucinations and gustatory. They're smelling things, hearing things, feeling. All right. That's extremely important and needs to be treated, which we'll talk about later. With acute alcohol withdrawal, they can look very like manic with psychotic features. They can look identical to that, but they're not. It's alcohol withdrawal. And I can share with you when there's a clouding of consciousness along with the psychosis and acute withdrawal, that's a medical emergency. They need to go to the ICU. They need medications and a lot of fluids, et cetera, et cetera. Okay. Now, when it comes to post-acute withdrawal, chronic, don't quite often see the psychosis unless it's associated with Wernicke-Korsakoff's, which we don't have time to get into. There can be a chronic cognitive impairment associated with a chronic psychosis. That is a pretty much permanent brain illness now because of the chronic alcohol. Haven't seen a lot of that. Wernicke's we often see beforehand, which we can treat with vitamin B1, and it helps prevent it from going to this Korsakoff's. But again, we don't usually see that. The most common stuff we see during withdrawal from alcohol, and it's not uncommon, is psychosis during acute withdrawal. Sedatives. I'm not going to go over this because it's the exact same as alcohol. It's like dry alcohol. During acute withdrawal, exactly the same thing. You can have the psychosis, and we'll talk about treatment of that. And they can look extremely agitated, anxious. I can't tell you how much time, and I'm going backtracking just a bit, people who have been diagnosed with bipolar disorder, they were just had severe anxiety. Because they try and get focused, they can't, they're highly distractible, they can't sleep, they're all over the place, they're talking with pressured speech, but it's anxiety, not bipolar. That I see quite often. Just had to backtrack. Sorry. Stimulants. We'll bring this up again later. During intoxication, especially of methamphetamine, you can definitely see, or cocaine, you can definitely see the manic-like episodes. And of course they can also be psychotic. During cocaine, that psychosis is usually again during intoxication. Methamphetamine, it can be intoxication as well as post-acute withdrawal, and that can go on a long time with amphetamine and methamphetamine, upward of a couple of years if you haven't already unearthed a premorbid potential for schizophrenia, which is a different story, and that takes a long time to figure out. But methamphetamine and amphetamine can induce long-term psychotic symptomatology, intoxication and psychosis. With cocaine, I'm sorry, that's usually just during intoxication, not during protracted withdrawal. You much more often see the depression during protracted withdrawal. I can share with you, if you look at cocaine as an example, they'll use cocaine, they become very manic-like, hypomanic-like, maybe even psychotic. They come out, they stop using the cocaine after their binge. Now all of a sudden they're very depressed, and that depression can last up to 2 years. Well, you keep having binges off and on like that whenever they can afford it, and they run out of money. It looks like bipolar. Sorry, folks, it's not bipolar. Get the rest of the history. I'll talk about the example I was going to mention in just a second. Okay. All right. So I guess I sort of hinted around what needs to happen here, but let's get through this. One thing is obviously urine drug screening. Extremely important to get urine drug screening. You want to, as part of your evaluation, you need to know what they've been using. This chart, which you have access to, tells you how long substances stay in the urine for urine drug testing. I'm not going to go into that right now, but you will have access to that. Fentanyl is so common now, it's extremely important to get screening. Okay, there is point of care screening test for fentanyl. It's immediate. Unfortunately, as I said, fentanyl is often mixed with many drugs. Individuals, like I mentioned, don't even know they've been taking fentanyl. And certainly fentanyl complicates the whole detox. Medication-assisted treatment process, which is a whole nother discussion. But that being said, screening and confirmation testing is extremely important to understand the difference. And you get screening, which is what you do right there. You pee in the cup, and then you read it there. You put a dipstick in, you read it there. That's a different type of testing, okay? That's something called immunoassay. There can be a lot of false positives, a lot of false negatives. I won't get into the chemistry of that. It's basically up to 50% can be false positive or false negative. So see on this slide exactly where some of those numbers lie, and I'll explain that in just a minute. With point of care testing or screening, which is stuff you do right there and then, higher cutoff levels, technologically higher cutoff. So anyone could be using drugs, but if they don't make that cutoff level, it's going to yield negative. It can't identify, unless in higher quantities, Ativan, Klonopin, or Xanax. Okay, and reasons for false positives, because this type of technology is being used, it can confuse other substances for those drugs. It's basically a point of discussion. If it's positive, it's a point of discussion. If it's negative, you sort of have to go based upon what the patient's been saying. Confirmation testing, the gold standard is liquid chromatography, mass spectrometry tandem, which is there. I won't get into the methodology. Basically, you send it out, a little more costly. Insurance quite often covers it, but there are no false positives, no false negatives. It gives you a number, how much is actually in the system. That's the gold standard. This is from Project Save Lives, which is our emergency room program. I want to sort of show you how much we're seeing here. Looking at like 50% of the folks coming in are positive for alcohol, 31% cannabis, cocaine, 58%, opioids, 31%, amphetamines, 35%, benzodiazepines, 31%. You can see even gabapentin is being abused. That's without prescription. We're seeing a lot of different substances being used out there. Very few, by the way, like it used to be, oxycodone. We don't see that as much anymore. The pill opioids. Now, here's the most important thing, which I've already mentioned. Look at this. Fentanyl with 2 or more substances. A large number. Fentanyl with 3 or more substances, still a significant number. Fentanyl with amphetamine, fentanyl with THC, cocaine. You can see how it's getting mixed, and people don't know what they're getting. But the picture is so complex, real challenge, and it's important to get that urine drug testing. Give you your best guess as to what might be going on and confirmation or not of what the patient already is telling you. Very important factors. Must have that history. Got to have that history. Okay. You got to know what the symptoms are, depending on what drug they're using, what symptoms are during the intoxication of that drug, during the use of the drug, during withdrawal, and during post-acute withdrawal. Getting those phase-specific symptoms are extremely important in discerning what impact the drugs might have on the actual symptoms you're seeing. Okay. Focus on duration of symptoms in each phase and timing as it relates to the potential psychiatric symptoms. And we'll get into some examples of that. Very important. What are the symptoms during times of abstinence? Okay. So if a person has been abstinent for 3 years or 4 years and they didn't have any symptoms, but they do when they're using, well, obviously it has to do with the drugs or the alcohol. It's extremely important. And by the way, I failed to mention, now you've got fentanyl, by the way, in pressed pills. So people think they're taking Xanax, they're taking fentanyl. Quite often they die. They look like they're taking oxycodone, but it's really fentanyl. So fentanyl's everywhere. It's really incredible what's happened. But focusing on times of absence, reaching back. Have you been absent? How long were you absent for? What happens to the symptoms then? That's extremely important. Okay. Please don't give a definitive diagnosis while a person's intoxicated or withdrawing. Okay. Having a family history of some of these disorders is a guiding factor, not a definitive factor. So a lot of folks in family history have also been using drugs and been misdiagnosed. Again, look for the windows of clean time. If you're going to get psychological testing, please wait till they're through withdrawal. All right, that's important. And remember, a diagnosis can have permanent ramifications. Not only can the patient start identifying with it and they become attached to the diagnosis, but it can have permanent ramifications on getting insurance, getting life insurance as well as healthcare insurance. Okay, what I'd like to do is take a 5-minute break, and then we're going to come back and talk about treatment and some scenarios and what we do with them. Is this a good time?
Yes, this is a great time. Okay, everyone, we will meet back right at 3:09. See you all then.
I told your wife before.
Okay, everyone, welcome back to today's webinar. I hope everyone got a second to use the restroom and get some water to drink. And we are going to welcome back Dr. Pomm.
Okay, hello again. I know that first part was a lot of material. I hope it made some sense. Again, my frustration with webinars, I can't see heads nodding or inquisitive looks or people are sleeping. So I'm going to trust that it made enough sense to move on, because as we move on, we will review some of what we've already spoken to anyway. So let's start. See if I get my direction correct again. It's weird. It's the down arrow. To me, I'm moving forward, but this is the down arrow. My natural tendency wants to move up, which is forward, but whatever. That's my problem. All right. So, when it comes to most of what we're seeing here, the acute episodes, when it comes to co-occurring, we're looking at someone entering a detox kind of facility. You might see it in outpatient, but they probably need, if they've been using substances, to go into detox. If they're having any of the symptoms I've been describing to the severity that we've talked about, where it's psychosis involved, they need to be in a detox facility. They might end up in a mental health facility. I can tell you with Project Save Lives, we're also involved in the ED of 7 hospitals. I can share this, which is an interesting bit of data. Memorial Hospital has a psych unit. We've been there the longest as far as hospitals that have an emergency room and a psych unit. I can share this with you. 50% of the Baker Acts get rescinded now because of our presence and evaluations in the emergency room. 50% of Baker Acts get rescinded in the emergency room because it's substance related. That's how powerful this stuff I'm talking about is, okay? That's how important it is. They don't need to be Baker acted. They need to come in a detox, okay? But whoever Baker acted them, maybe at that point they didn't have enough time to get the proper history, but our peers are getting this history. And it's very frustrating to me, again, how many people are misdiagnosed because of not getting the appropriate history or asking some simple questions about, have you been using drugs? What drugs have you been using? It's okay. You can tell me. I'm not going to judge you. It's just going to help me help you. Okay. So that 50% figure, don't forget that. It's extremely important. All right. When they come to detox, I got to share with you basics. One basic is I have 2 criteria for our treatment of folks in detox. It's comfort and safety. If they're not comfortable, and I don't mean like Malibu comfortable, I mean, with treatment or control of enough symptoms where they're comfortable, where they don't want to run. They run, they're going to use again and potentially die. Okay, that's the comfort I'm talking about. So again, if they're not comfortable, they're not going to stay. If they're not safe, then obviously we're going to have a seizure or something else on our hands that we're going to have to deal with. So comfort and safety are the 2 basic criteria for our patients that are in our detox, okay? It's extremely important to stabilize the basic withdrawal first. So alcohol withdrawal, there are 2 schools of thought. One is symptom-based and one is protocol-driven. I'm just going to share my opinion, okay? A lot of people support my opinion, but there are other people that support the other opinion. I like protocol-driven, meaning that when we've identified it, let's say alcohol withdrawal, that we start them on a protocol at the appropriate time, which I'll mention in just a little bit, which means set dose over time, weaning over time. In 5 days, you're done. Whereas symptom-based is you have symptoms, nurse gives you medication. You have symptoms, nurse gives you medication. Why don't I like that? Because symptom-based is usually done with Valium, it's usually done with Ativan, which is short-acting, number 1. Short-acting medications fall off pretty quickly. You start having symptoms again. It's like a roller coaster. Okay? I don't like roller coasters like that. I mean, I love roller coasters, but I don't like roller coasters like that. I like to keep someone's symptoms at bay on a consistent basis. That's why I like using the longer acting medications like Librium. Okay, but symptom-based also, it's reinforcing their addictive behavior. I don't feel good, give me a pill. I don't feel good, give me a pill. I don't feel good, give me a pill. When I took over Gateway, they had been treated symptom-based. And when I moved over to protocol, the nurses loved me. They don't love me anymore, but anyway, kidding. Oh, it was like this symptom-based stuff. You got people coming to the nurses station all the time. Give me a drug, give me my medication, give me my medication. Well, that doesn't help the whole psychological component of addiction. Okay. And again, they're on this roller coaster. I want them comfortable, stable, comfortable, which is much more related to the longer acting medications. Why I don't use Valium, and I can share with you, I work with another organization that used to use Valium. Valium causes people to get high. Librium tends not to. Addicts love high. I'd rather stay away from high because then they start feigning symptoms. It becomes more of a complex problem for the nurses, more problem for the nurses in terms of evaluating where they really need it or do they really have symptoms. And so it's funny, after I changed the protocol from Valium to Librium, one of the first patients that came back that needed detox again to this facility said, what protocol are you using? They said, Librium. You're not using Valium any? No. Okay, goodbye. He left. I do my best. I'm trying to do my best to reduce the my role in their addictive behavior. Okay, that's all right. I mentioned about short half-life, with shorter life. That's again that roller coaster. Longer, it's much more stable. And when I'm sorry, with benzo withdrawal. I'm sorry. With benzo withdrawal, again, I use basically Xanax is the most common one, and I use Klonopin. I'll just say, I'm not going to get into all the protocols. That's not the purpose of this. I basically use the Klonopin protocol. We have a couple of protocols. Want to stabilize them. Want to get that the peaks and valleys out of there, where they're having trouble with withdrawal part of the time and feeling okay. The other part, I need it stable because I got to evaluate these people. I got to see what symptoms are left when they're not going through withdrawal. When they're using alcohol and benzos, it's a similar different story. It's a similar story. We have protocols to handle that. Again, I like that consistent, stable effect. Methamphetamine, to be honest with you, there are no protocols for this. We treat symptomatically. Obviously, if they're agitated, we're going to treat them for the comfort, not necessarily for safety. And by the way, when it comes to alcohol or benzo, one of the safety risks is if you don't treat it well enough, they're going to have a seizure. And you don't want that to happen either. Back to methamphetamine and amphetamine, we're basically treating symptomatically, mostly agitation, and we'll talk about treatment of the psychosis with that. Same with cocaine. Again, treating the agitation is no protocol. Chances are they're not going to have a seizure, but you do want to keep them somewhat comfortable until that initial agitation phase fades out, and you might be left with some psychosis, which we will talk about. Okay. And again, with opioids, comfort medications, I'm not going to get into all this. Most opioids do not cause psychotic symptomatology. You do want to feel comfortable. Again, you can have a combination of opioids, methamphetamine, alcohol, and benzos. You treat them as they need to be treated. Even though there's a combination, you still got to treat the alcohol or benzo withdrawal. You've got to do that. Okay? That's the first thing you actually have to do. You've got to get why? Because the risk of seizure is more critical with alcohol and or benzo withdrawal. So you've got to make sure you reduce that risk. There's another reason too, which I'll get to in just a minute. In order to better assess opioid withdrawal, you've got to stabilize that alcohol and benzo, both for comfort as well as safety, as well as assessment reasons. Then you can deal with the opioids, okay? When it comes to alcohol and benzo, when it comes to alcohol and Xanax, here's where showing you that the greatest risk for seizures in withdrawal is upward of 24 hours. The greatest risk for DTs, which is that combination of sort of clouding of consciousness, tremors, alcohol, benzo withdrawal, with potential psychotic symptoms, very dangerous. That's called DTs. The greatest risk for that is upward of 72 hours. So you're not out of the woods until well into the 4th and 5th day. And even then you can have some stragglers. Very important. If they've had a seizure disorder, if they've had withdrawal seizures before, withdrawal delirium tremens before, they're a much greater risk of having it again. So it's extremely important to treat. Where psychotic symptoms come in on that, I will tell you in just a couple minutes. I just need to get some basics done. This is extremely basic because obviously if they had a seizure, it's potential life-threatening. DTs are also potentially life-threatening. All right, some of the screening tools we use. Alcohol concentration. I can share with you, we see our share of people who have 0.3 and up to midpoint 4s. Look what it says, 0.4 to 0.5. Well, tolerance is an issue. And you know, I've seen people with a 0.42, a 0.43 walking and talking like they're not even drunk. I'm talking about people that are drinking a gallon a day and drank in the parking lot. It's incredible what tolerance can do. I'll be honest with you, the parameter for our facility is if they can walk and talk and not a fall risk, we can do a nursing assessment, we'll treat them. If they can't walk and talk and they are a fall risk, then we send them out to the emergency room. And usually they give fluids and start some withdrawal medicate treatment. But as long as they can walk and talk, I'd much rather hold them there, treat them, and get them under control, because by then, minutes are important. I'm not kidding. Within an hour, they could be into DTs or having a seizure. So transporting the Medicaid to ED, emergency room, having them wait, whatever, you want to try and avoid that. But obviously, if you can't assess them, you got to do it. So we don't base our admission on BAC as much as ability to do our assessment and treatment. All right, this you can't really read, so I'm going to refer you to it. Our alcohol or benzo withdrawal assessment tool is CIWA. You probably are all familiar with it. 10 is typically the magic number. Basically, what it actually is assessing. I'll just give you some: anxiety, tremors, diaphoresis, some hallucinations, headache. Those are the biggest. Agitation. So those are the biggest ones. They're each given in numeric scales to severity. When it starts adding up to 10, that's usually the critical point. Sometimes they'll start earlier if they've had a history of withdrawal seizure, withdrawal DTs. Importance here, though, is this. It's the objective symptoms that are most meaningful. They will tell you all sorts of symptoms, but base most of your decision not just on the number, but the objective symptoms. They are tremulous. They are diaphoretic. They are agitated. They are having hallucination. Okay, these are things you can actually see and measure. When it comes to opiates, it's another one, clinical opioid withdrawal scale called COWS. Again, it also has you're grading each symptom. Again, sweating, restlessness, pupil size, a tremor, yawning, goose flesh, anxiety, irritability. So again, 10 is a magic number where we would start treating. However, I want to show you very clearly, if you were listening to me, even though you couldn't read it, there's some crossover. The most important one is the alcohol and benzo. You don't have a seizure, not likely to have a seizure with opiate withdrawal. They're going to be uncomfortable. They're not likely to have a seizure. You've got to treat and stabilize the benzo or alcohol one first. Okay? Because there's crossover, you're not going to get a real clean COWS score. Once they're stabilized from the alcohol and or benzo side, then you can get a clean COWS score and know what to do. All right. So you've got someone who's psychotic and they're going through withdrawal. There are some things you want to do first. Reduce stimulation if you can. Do not challenge the symptoms. Empathize with them, please. Okay? You don't want to run them off or cause a worsening of their symptomatology. Don't say, there's nothing here. What do I have to tell you? I don't see anything here. No one else sees anything here. That's not the response. or, no, their police aren't after. Don't argue with them. Okay? What I often recommend is this. Go back, imagine if ever you've been in a situation where you felt like someone was following you, you felt like someone was going to hurt you, how that felt. And if you've never been there, go back to some feeling where you felt threatened or unsure of what you saw and were scared. It's fear. Go back to that feeling when you talk to them. That's your empathic support. I call it empathic resonance. Patients respond well. It's a beginning of a trusting relationship. Oh my gosh, it sounds like you're really scared. Oh my gosh, how scared are you? Come at it that way. Don't challenge them. Okay. Not a lot of research has been done when it comes to managing acute psychosis in a substance abuse setting or where there are substances. Probably right now, the most consistently yielding medications are risperidol or Haldol. I'm not saying others can't be used. Olanzapine can. Olanzapine, Zyprexa. It can be used. I'll be honest with you. Sometimes we don't know how long we're going to have people on it. I have to think of long-term side effects. And olanzapine tends to have more metabolic side effects over time. So if we might have to keep them on it longer, rather not use it. Also for us, risperidol and Haldol, we're paying for it. Cheaper for us too. Very effective. Doesn't take much of a dose to get. It's basically big bang for the buck. But low dose, high potency. Okay. Again, the reason I don't use olanzapine is because of the potential metabolic issues. It's more severe than risperidol and more severe than Haldol. We'll talk about some other side effects though. Now, look, first generation like Haldol, we don't use Thorazine or Melrose. Haldol is probably the most common. There's Trilofan. There are other ones, but we'll stay with Haldol. So first generation, that's FGA. Second generation is your SGA, like risperidol. All right. So there are other first generation and other second generation for good for maintenance, but they're just not as effective for the scenario we're talking about. And as I said, very little literature on it. Okay. Some of the side effects that you could find, okay. Extrapyramidal side effects, which is basically shuffling gait, stiff affect. I don't have a way of showing you how to check for cogwheel rigidity, where it's ratcheting of the arm. Basically, that's treated with cogentin. Quite often don't start it unless there's a past history of it at low dose on these medications, or we start seeing it. Akathisia, we quite often don't see, but that's basically, where they can't sit still. It can become a little confusing. You might have to treat it. The one I really want to talk about is something you might see once in a while. We don't see it often, but actually seen it a couple of times in the last couple of months. Something called acute dystonic reaction to the medical Haldol or risperidol, usually, where they look real scary, actually. Eyes roll back, could be head and body go back. They can't speak right. There's like thick tongue, neck, which is torticollis, neck's off to the side. It looks like maybe they're going through a seizure. It looks scary. Basically, we give them a little Benadryl IM or cogentin IM, and it gets rid of it right away. I can tell you, I got to reassure staff on a regular basis, just give the medication within 10, 15 minutes. It'll go away, automatically start medication to try and prevent that. But that's just sort of give you an idea of what you might be looking for, whether you are prescribing, administering, or just they're one of your patients. And these are things that you probably should just know. You might not need to know the actual treatment, but suffice it to say the professionals that are administering the medication should. And those that are on this webinar, hopefully this gives you some guidance. Okay. All right, let's go to some scenarios. And what I want to do is we're going to try and do this via webinar. So I'd like you to put your answers in the chat to all panelists. Okay, it's chat to all panelists. Someone will be reading it. It's too distracting for me, sorry to say. And I'm going to give you the scenario, and we're going to let you take your best guess at the potential answer. Scenario 1, 49-year-old male with no known psychiatric history comes in with no medications, drinking 1 liter to 1 gallon of vodka per day. BAC is 0.387. He's walking and talking as if not intoxicated. C was 0. Vital signs are within normal limits. 2 hours later, BAC is now 0.30. And he starts talking about seeing people others don't see. He's only oriented person. Looks like he has clouding of sensorium, not quite sure where he is, looks sort of out of it. And he has significant tremors and sweating, which is diaphoresis. Okay, tell me what you're seeing and what you want to do, if anyone is brave enough. I'll give you just a couple minutes, because we have 7 of these. I will eventually give the answer. When was last intake? You mean drinking? Okay, alcohol withdrawal. Yes. Got to take it deeper. Now I know. Alcohol detox causing hallucinations? Yes. You're missing a very, yes, Mark. Okay. All right, so we got alcohol withdrawal, need for detox. So we have one person that got the entire thing. Look, folks, look at it really clear. Yes, he has hallucinations. Absolutely. Okay? He's got visual hallucinations. No question about that. Yes, he is probably starting to go through withdrawal, but we're not seeing much of it except tremors and diaphoresis. So those are indications of some withdrawal. The key here is clouding of sensorium, only oriented to person. This is DTs. It's a medical emergency. Call 911. Nothing more. Call 911. Okay? Ambulance should be picking them up and taking them immediately to the emergency department. They might even require an ICU admission. There's a guy I just heard about at Baptist. They've been trying to get her out of this delirium state for 3 weeks. They have been unsuccessful. It is rough. I had a guy I can share with you. Notice the BAC drop again. I want you to see it. Went from 0.387 to 0.30. I had a guy, I was consulted to the ICU because the guy was diaphoretic, tremulous, agitated, having auditory and visual hallucinations, auditory hallucinations, and he didn't know where he was. He thought I'm just going to say what it was. Sorry to get somewhat sexual on this one, but he thought the nurse and the quote unquote aide were having sex on the floor next to him, and he could feel their body heat and hear the sounds they were making. Okay. And he didn't know really where, he didn't realize he was in the hospital. Okay. This guy was in DTs. Here's the here's the interesting thing is he promised his wife he would not drink at the Jaguar game. So what he did was he drank in the parking lot. He went into DTs halfway through the first quarter. It is the relative drop in BAC, folks. You don't have to wait for no alcohol to be in their system. They could go through withdrawal symptoms in this severe case of DTs. You can go through it just with a slight drop in BAC. You can also have a seizure during that time. Extremely important. Okay? Please, they might have lucid moments. I'm going to mention this. They might have lucid moments. And if rescue comes and they're in a lucid moment where they know where they are, don't let rescue leave. Just say, look, this is exactly what I've been seeing. He's in a lucid moment. You got to take him. I actually had a call and have the rescue brought back. And when they came back, sure enough, he was no longer in a lucid moment. So anyway, very important. All right. Next one. 29-year-old female, no prior history of medical or psychiatric problems. Drinks 2 bottles of wine per day. Last drink was yesterday. BAC, 0. ETG, which is a minor metabolite of alcohol, shows alcohol usage within the last, they say up to 5 days. It's really the last 2 to 3 days. Other urine drug screen, negative, so just alcohol. Okay. BP, 180 over 110. A lot of folks freak out at that. Pulse, 130. A lot of folks freak out of that. CWA, 21. I said 10's the cutoff. They are in full-blown withdrawal, agitated with severe tremors, believes people are going to find her and hurt her. Delusions, visual hallucinations, agitated, severe tremors. What are you going to do? Remember, a lot of scary stuff going on right now. What do you want to treat? Told you most of it already, by the way. Silence. Oh. Well, a lot of folks can't give them fluids, but fluids would be great. Can't do it at Gateway, I know that. Likely DTs, call 911. Interesting. There's no delirium. You can't have DTs without delirium. Clouding of consciousness. Okay? Not DTs. No delirium. This is alcohol withdrawal hallucinations and alcohol withdrawal. Any other questions? I mean, answers? Sorry, I'm asking questions. Sorry about that. Got confused, didn't I? All right. Without belaboring the point, let's slice and dice this one. First, do not, I was thinking people would say, let's get that blood pressure then. Do not treat that blood pressure independent of withdrawal. Remember what I said, no prior medical or psychiatric problems. If I treat the blood pressure separately, which a lot of people wanted to, and trust me, nurses have begged me to treat that blood pressure separately, I've now taken away a parameter by which I can assess withdrawal response and response to my treatment of withdrawal. Okay. So I'm going to treat the withdrawal. In this case, I don't want to get into the specifics. I'm probably going to give Ativan. It's much quicker acting. And sure enough, it's amazing when blood pressure and pulse are a result of withdrawal, that blood pressure comes down very quickly with Ativan, not treating the BP, the blood pressure, separately, okay? So I'll often give Ativan in this situation, also start a Librium protocol, whatever. I don't have time to get into all the protocols. Here's the issue, another issue, she's having hallucinations, okay? All right. Don't treat the psychotic symptoms. Okay. Why? Both first generation and second generation antipsychotics reduce the seizure threshold. She's already at a high risk for seizures from withdrawal. We don't want to put a nail in that coffin and induce a seizure. You want to go ahead and start the treatment of the withdrawal. As I said, Librium protocol and Ativan or whatever there is that your institution is using. Okay, we're going to treat those withdrawal symptoms first and get them under control. Of course, push as much fluid as you can. That can help bring the pulse down. Okay, and then thiamine to help that Wernicke's-Korsakoff from not developing, nutrition, et cetera, et cetera. Now, you treat the withdrawal first with those benzos, with that protocol. If the symptoms of psychosis don't go away, and now they've had several doses of benzos, or the protocol, benzos are also anti-seizure medication. Okay, So with enough blood level of benzos, I can now use the Risperdal or Haldol and not worry about reducing that seizure threshold. If they're very agitated, I might have to give more Ativan with it. If they're compliant, basically I can give it by mouth. And if you give it by mouth, you'll see a response within 30 minutes to an hour. If you give it intramuscularly, you'll see the response in 15 minutes, okay? And again, checking for side effects, all right? And beware of those side effects I talked about. Y'all got that? Y'all understand what I did step by step? You've got to make sure they got enough benzo on board before you treat with the antipsychotic. Otherwise, you could potentially send them into a seizure. Don't want to do that. A lot of times treating with the benzos, the protocol, that often will do well enough to get the psychosis under control. It's only if it doesn't, after their withdrawal symptoms are better, that you want to go ahead and start it. So Mark says, would Keppra help decrease seizure threshold? Absolutely. No, it helps increase seizure threshold, Mark. So it helps reduce seizures. Yes. And a lot of people will give Depakote or Keppra. I'll be honest with you, we have to, we're in a situation where we pay for all of our medications. And so a lot of people do that prophylactically. I would still get enough benzo on board and try and let the benzos treat the withdrawal symptoms before you commit to treating the psychosis. But unless it's out of control, yes, if it's out of control, for sure, you can give an anti-seizure medication in order to get the acute psychotic symptoms under control if they're like busting up the unit. But you might have to call JSO, to be honest with you, and Baker Act initially. But depending on the level of severity. Okay, going to move along. All right. Now, you get them on a psychotic, they're doing well, it's usually relatively low dose. What you want to do is, assuming it's alcohol or benzo withdrawal seizure, you're basically going to only keep them on it for a couple of days and start slowly, pretty quickly weaning it over the next couple of days, because they shouldn't need it. You don't want to keep them on those medications any longer than you need to. Now, if you can't get them off, it's a whole different story. What else is going on? This one had no prior psychiatric history. More than likely, you're going to be able to get her off. Okay, might have to keep her on a little longer, but usually it's not more than a few days. Okay. All right. Oh yeah. So when it comes to the benzo part, I don't want to get into all the different protocols. Xanax is the most common. Again, it's CEWA driven. Again, using CEWA, they can have delirium just like alcohol, and the psychosis exactly the same as scenario 2. Okay, so rather than alcohol, you can plug in benzos, and then you would treat almost exactly. I threw phenobarb in there just because sometimes people are using so much drug, our protocols don't cover it. Phenobarb is a good drug to cover it. It's also anti-seizure medication. The problem with phenobarb is it interacts with everything in the world, and our folks leave AMA a lot. I don't want them to have a high phenobarb level, go out and use their drugs, and I've now contributed to their death. So I try not to use it unless I absolutely have to, but that gets into more weeds than I'm able to here. Okay. Again, when you look at CEWA, let me emphasize again, objective symptoms are important. All right, let me try and get through these. Scenario number 3, 60-year-old homeless male, black homeless male with a 40-year history of cocaine use disorder, prior Baker Acts for bipolar disorder and or schizophrenia, and treated with multiple mood stabilizers, first generation and second generation antipsychotics, as well as SSRIs, never stayed on his meds, couldn't afford them. Last Baker Act, 3 years ago. Was in prison for 5 years, 10 years ago, secondary to burglary. During that time, he was not given any psychiatric treatment. Used cocaine in the parking lot. His urine drug screen was positive for cocaine and fentanyl. He knows nothing about fentanyl. He presents as agitated, paranoid delusion of police hiding in the parking lot, sweaty, tremulous, hyperverbal, flight of ideas, rapid heart rate, BP 160 over 90. So, what is the unlikely diagnosis? Why? I can hear the silence. Not a trick question. What diagnosis does he not have? Chances are, what diagnosis does he not have? All right, I don't want to belabor it. Folks, I missed some of those chats. So let me go right to the first one is not likely bipolar or schizophrenic. Why? He was in prison for 5 years and didn't require any treatment. Trust me, if he was schizophrenic or bipolar, he would have needed treatment. Chances are he's not bipolar or schizophrenic. Chances are this is cocaine intoxication. During cocaine intoxication, remember what I said? That's when they become psychotic. He just used it. Delusion. He's diaphoretic. He's tremulous, hyperverbal, looking just like bipolar. Tachycardic, chances are that kicks him over into the cocaine too. Don't find the tachycardia typically with bipolar or schizophrenic, unless they're really scared, which it could be. By BP's up. It's another indication it's much more drug-induced. You follow my thinking? He had 5 years of no treatment, and apparently no symptoms of severity that required treatment, which would be typically in bipolar or schizophrenia. Didn't have it. He's been on all these medications. He's got a 40-year history of cocaine. He's been Baker acted for this. How many? I said 50% of the Baker acts have been rescinded because of drug use. I gave you all the hints, folks. Okay. All right. Don't want to belabor that. Hope that makes some sense now. Move on to Sarah number 3. Oh, well, I'm sorry, we're in 3. So obviously in this case, we want to reduce symptom stimulation, empathic, non-judgmental, non-challenging responses. Okay. If he's agitated, I would use Ativan for the agitation. Why? Okay. Because it's cocaine intoxication. As the cocaine leaves the system, that paranoia and agitation will likely go away. Certainly check the cows because we don't know how often he's been using fentanyl. He doesn't know. We might have to do something with opiates, but we got to check the cows in order to do it. It might just be a one-time, last time he used it, or every once in a while. Don't know. Okay. 40-year history, out of control, cocaine use, obviously recurrent hospitalizations for it. He probably needs residential treatment. Okay, scenario number 4. 28-year-old mildly cachectic homeless female seen in the emergency room. I was consulted due to, this is a true story, consulted due to multiple state hospitalization admissions with diagnosis of chronic paranoid schizophrenia. Prior treatment with first-generation antipsychotics, now taking meds now, presents with a history of drinking a 6-pack plus of beer a day, last drink today, but negative BAC, mild tremors and diaphoresis, thought process linear, no evidence of psychosis, engaging and friendly, a good historian. So what is obvious from this presentation? Last drink today, negative BAC, mild tremors and diaphoresis. So what's starting to happen? She's starting to go through withdrawal. Correct? Now, the next thing I said, remember. Oh. Yes, thank you. Not schizophrenic due to engaging and friendly, unusual for a chronic schizophrenic. Unusual. That doesn't mean it, but it's unusual. And she's not psychotic right now. Okay. So let me move through this because we're going to run out of time. I asked her history, and let me tell you where her history was. Okay. She was drinking, ran out of money, went through withdrawal, became psychotic, admitted to a hospital, treated for psychosis. In those days, we used to send them to state hospitals quite a bit. Put on medication, they controlled the psychosis, they discharged her, she ran out of money, couldn't afford the medication, but she could afford enough alcohol. So she started drinking again until she didn't drink again. Same story several times over. This is a true story, folks. A true story, repeated history of this. What I do? I sent her to detox. Okay? She did great. Was never a schizophrenic. All right. 32-year-old Hispanic male seen in an outpatient clinic, long history of bipolar disorder and psychotic features. A long-term treatment with haloperidol, 20 milligrams BID. That's a pretty good dose. Here for continuation of treatment, refill medication. Long history of cocaine use disorder, $50 to $100 a day. History of multiple short-duration manic episodes, symptoms, followed by major depressive symptoms. Psychotic symptoms only during manic phase. During interview, mental status was only positive for depressed mood and affect. Urine drug screen was negative. Involuntary chest wall movement noted, very motivated. And I had to call the prior treating physician. What's the probable diagnosis? Psychotic symptoms only during manic phase, folks. What's the underlying cause of the chances are the cause of the manic phase? Cocaine intoxication, folks. Yes. Got some right answers. After they get off the high of the cocaine, what usually happens, they go into a fairly significant depression. Well, there it is, folks. Followed by depression. Diagnosed bipolar. What's he got? Involuntary chest wall movement. He's got tardive dyskinesia from the Haldol. That can be permanent in 1/3 of the cases. Another third can take up to 18 months to relief. Another third can, be relieved relatively early, but you're risking long-term permanent movement disorder. Now, I called the doctor. This is a true story, and I explained what I saw, and her response was, "I don't know anything about that. That's your field." And that was the end of the conversation. What'd I do? I got him into outpatient treatment for a cocaine use disorder because he was very motivated and he hadn't used in a while. And on top of that, I started reducing the Haldol. I eventually got him off the Haldol. He never needed it. I treated his depression with an SSRI, outpatient treatment for medication management, as well as his drug use. And he was fully employed and never had a symptom of bipolar disorder again. True story. Unfortunately, seen too often. Scenario number 6. 36-year-old Caucasian female presents with a history, long history of methamphetamine use disorder, daily use. H&P within normal limits, vital signs within normal limits, mental status within normal limits, except for complex delusional system involving ex-boyfriend and police. He was a law enforcement officer. The plans were to find her and set her up. She was seeing dust particles coming from the vent. They would merge and become little animals. This is a true story, okay? She was very animated and engaging, highly intelligent. I mean, she's the kind of person all the staff said, God, I could see being her friend, And she felt very safe in the treatment center. Diagnosis. Well, what's the differential diagnosis? Take some stabs at it. What am I looking at? Silence. Withdrawal from methamphetamine. Correct. All right. So we didn't really have a good history on her. Again, it could be delusional disorder because she's got a complex delusional system. Unlikely delusional disorder because she also had hallucinations. So she certainly met two criteria. Criteria A of schizophrenia. So you got to sort of look at schizophrenia. Is it, isn't it? Okay. How long has it been going on? It's been going on for months and months. So it could actually be schizophrenia. So then we're looking, however, at the methamphetamine. And what ended up happening was, again, she felt safe in the treatment center, so very circumscribed. What we ended up doing was we ended up treating the psychosis, the delusions, and the hallucinations with low dose. I don't remember if it was Risperdal. I believe it was. Here's the interesting thing. So she absolutely needed residential treatment. She went into residential treatment. We were able to help her with her delusions and hallucinations with the Risperdal, but it was months. She had those symptoms for months, and eventually they went away. And we were able to take her off the antipsychotic. And we would try weaning it at various times, and we couldn't. So we try again, we couldn't. Okay, but always trying to achieve the lowest dose. You don't want to commit them to lifelong because you don't know. These symptoms can go on for a year or two. And again, sometimes they could cause an emergence of a pre-morbid potential for schizophrenia. But you know what? She was animated, engaging, it was very pleasant to talk to. So she got through residential, psychosis under control, no more of the psychotic symptoms. She did well, left, and I don't know how much longer, and she came back. Methamphetamine, exactly the same presentation. So, all right, one left. We're going to make it. 65-year-old Caucasian homeless male with long history of daily half-gallon alcohol, fentanyl, and methamphetamine. Last use of all substances this morning. Had a positive ETG, BAC was 0, unknown medications, vital signs 160/110, pulse 140. Unknown medical history, nothing physically noted on the nursing assessment, like for instance, jaundice, not noted. Okay, as an example. Here, CWA 15, COWS of 18, agitated, diaphoretic, nauseated, tremor, major symptoms. Visual hallucinations, but they were mostly distracting. He was oriented, and he wants buprenorphine for the fentanyl. What are my priorities? Remember, folks, comfort and safety. Safety within the withdrawal protocol for alcohol first. Yes. I've got to make sure he doesn't have a seizure or go into delirium tremens. I also have to make sure that whatever crossover there is between the CWA and the COWS is taken care of. So I've got to treat the alcohol withdrawal first. Once we've got those alcohol withdrawal symptoms relatively under control, that should also bring his vital signs down. His blood pressure, if his pulse is not coming down, pushing fluids will also bring that down and help bring it down. Then we can deal with what is the real number for the COWS for the opioid withdrawal. That's when we deal with that. We look at it. And this is a whole nother topic, which I'll be talking about in about a month. How do we deal with the starting the buprenorphine? When do we start it? How do we know when to start it? How we deal with all that stuff. But that's when we begin our assessment of the need for buprenorphine. So that's, I believe we are now at, I hope that's all clear. Are there any questions before we wrap it up? I hope this was helpful. I hope it clarified some things for you and maybe either affirmed what you're already doing or actually helped you in developing some different ways of looking at things. So I thank you so very much. And I want to say goodbye.
Well, thank you so much, Dr. Pomm, and we appreciate all the work you've put into this and what a great webinar this has been. And I can see some people are commenting that I don't know if you can see that. Thank you. This was a great presentation. So that is just wonderful. And we thank you for coming and joining us today and sharing this information. So everyone, just a couple of items of business before we conclude today's webinar. Please see the chat panel for a link to today's survey. Additionally, when I conclude today's webinar, your browser will take you to an evaluation on FADA's website. If you want to receive CE credits or statement of credit for this event, please complete the evaluation. Also, if you have further questions, you can see Dr. Pomm's email on here and you can reach out to him. You will be prompted to register or sign in to complete the evaluation. You can register as a visitor at no cost. For CEs to be reported to CE broker for Florida licensed healthcare practitioners, please provide an accurate Florida Department of Health prefix, license, and number the first time you register, or please make sure you update that for reporting to CE broker. After you register or sign in, you will be directed onward to the evaluation. You will need to use the same email address you used when you registered for today's webinar through WebEx when you set up your profile in FADA's system. This is the only way to connect your attendance and your profile. You will get a second opportunity to complete the evaluation through a follow-up email later today. The sender will be Messenger at WebEx. Please remember the evaluation closes midnight Friday, April 15th. We do not email statements of credit. Instead, after we verify attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile. If you are unsure how to access your journal entries, please visit our website and look at our CEU and frequently asked page. Again, thank you for participating in today's webinar. We'd like to recognize and thank OSCA for putting on this wonderful webinar today and for funding today's education. Have a great rest of your day, everyone, and have a good evening.